Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Ribs.
We're going to be demonstrating a rib procedure for you today. We're going to be focusing on a series of 3 projections. You're going to be doing an AP for above diaphragm. You're going to be doing an AP for below diaphragm exposure, and you're going to be doing an oblique for above diaphragms. So that's 2 14 by 17 films for above diaphragm images and 1 10 by 12 below. It is preferable to do a patient at the vertical board. Rib injuries are very, very painful. If the patient can walk, it's better that they stay in a vertical position. If they need to lie down, though, because they're shocky or in pain, what you could do is elevate your table with a footboard on and let them step up on the footboard, and then you can give them a ride down so they don't go through that pain of trying to get up on the table. What we do vertically, we would do recumbent. So the demonstration today, the information will be pertinent in either scenario. Right. Kristen is a walkie-talkie patient. I'm electing to do it at the vertical board. She's not a very large patient by any means, so I'm going to go with the pure positioning routine, and that's we're going to put her mid-sagittal plane to the center of the film, and the very first rib is up here at the apices of the lungs, so I want the film's edge 2 inches above her shoulders at this level. A lot of students might think this is the shoulder, but you have to think about where the first rib is, and it's right here. So the film's edge should be 2 inches above the shoulder, and shoulder is now defined as over the apices of the lung right there. So I'm going to look and make sure my film's edge is 2 inches above, and it is. Okay. Now we're going to just have her elevate her arm here for a second, and can you see the light here on the board? Again, her mid-sagittal plane's to the center of the film, and I have light on that board, and that means I have light on that side, so I am not clipping any portion of her rib cage. So I'm very happy with the centering of this. If she was a large patient and broad in shoulders, broad in the thorax, you might have to offset the patient a little bit. The part from reference point states the mid-sagittal plane to the center of the film. However, do not clip the site of injury. So you might just have to offset them a little bit, but look what would happen if we offset Kristen an inch. See how much tabletop we're x-raying? And that is not valuable information. So we're going to use the shadow of our light a lot during this demonstration. AP though, mid-sagittal plane to the center of the film, make sure the patient's straight. The edge of the film, the top edge, is going to be 2 inches above the shoulder at the apical area. And I have a right marker on to match the right side. Now you might ask, why am I doing this in an AP position? This particular scenario is set up for posterior rib injuries. She's injured on the posterior aspect, and we want to get those ribs closer to the film. So this is what we've set up now. And I'd have the patient take in a deep breath, as deep as they can, and hold it in. That will drop the diaphragm down. You can breathe. It will probably be, the patient may be able to take a little breath in, but if they're hurting, the diaphragm will drop some, but not as much as it will. We're having the diaphragm drop so we can get as many ribs into the image as possible above the diaphragms, because you have a density issue with tissue thickness in the body. Anything in the lung area above the diaphragm is going to be air, and it will be easy penetrated. So these ribs will be all of the same density, and anything below the diaphragm is going to be light compared to the lungs. Okay, so we want to drop the diaphragm down to get as many of the lungs as possible in a same density mode. So we've just now done an AP for posterior rib injuries on the right side with deep inspiration. If she's in a true AP position, the sternoclavicular joints will be symmetrical. And we will want you to be able to count your ribs. I want you to be able to recognize whether it was exposed on inspiration or expiration. So when we do film critiques, make sure you count the ribs, know that the diaphragm should be below the 10th posterior rib. with a good deep inspiration. So we can let our patient relax for a minute. And if I was doing this in a recumbent mode, I would do my AP small film next, so the patient doesn't have to move very much. But if they're walkie-talkie and they're already at the vertical board, it's not a big deal just to put them into an oblique position. So we would change films, ID blocker to the top again, 40 inches SID. And for a right posterior injury side, I'm actually going to do an RPO. So we're going to demonstrate the patient. You want her in a 45-degree oblique. This would be 90 degrees. Take her back halfway or bring her out halfway from the film, but 45 degrees. The purpose of the oblique is to lay out the lateral ribs. Okay? Some patients might need a 50-degree oblique. Some patients might be okay with a 40-degree oblique. You've got to think about the purpose of this position, and it is to lay out the lateral ribs. Patients who are bigger and rounder will need less degree of obliquity, and patients who are narrow and more oval will need more degree of obliquity. So I've put Kristen at a 45, and I'm coming in and I'm looking at her lateral ribs, and they're not really laid out for me, so I'm going to oblique her just a little bit more. See how I'm getting my fingers more parallel? That's what I want to do. Now this arm, if it was down, the tissue would end up getting into the rib. So we need to bring the arm out a ways. There's many ways you can do that. You can do it like this, or you could give them a pole to hold on to, you know, if you've got them ready, a pole readily available. And now, see how much light I have on the tabletop here? I know I've got to change my side-to-side reference point. I don't have to change the vertical because she didn't grow in between these two positions. She stayed the same height. But this way I've got to have her step towards me because I want as much of the rib cage on there as I can. And here's her clothes. This is breast tissue that I'm clipping here. And I just want a baby amount of light on the tabletop. And I look at this crosshair coming down, and I'm satisfied with that positioning for the oblique. You would have your patient take in a deep breath, as deep as they can, hold it in, make your exposure. Okay. And you can relax, Kristen. Again, don't make them hold that arm up there too long unless they're holding a pole, or you can bend it out. Something to get the arm away from the tissue of injury. Okay, again, deep inspiration to drop the diaphragm down, 45-degree obliquity with some flexibility in order for you to get the lateral ribs laid out, either increase the degree of obliquity or lessen the degree of obliquity. Your image on the x-ray, if it's at a 45-degree oblique, the affected side, the side of focus, will be twice as wide this way as the unaffected side. Okay, you can actually measure and see that. Do not x-ray tabletop. Get as much of the rib cage on there as possible, because the patient fell or they hurt themselves. They might have injured themselves in a couple of locations but are only feeling the pain in one. So make sure you get as much of the rib cage on there as possible. Okay. Now we're going to put her back into an AP position, and we have been able to demonstrate with a deep inspiration the first through the 9th and some of the 10th rib. That's above the diaphragm with good density. What we haven't been able to demonstrate with good density is below diaphragm ribs, because the abdominal tissue changes the density there, and we need to have different technical exposure factors, a higher level of mass. I'm putting a 10 by 12 in the Walbucky. I'm going to use a right marker. I'm going to put the right marker, the right side right there. Change my collimation to 10 by 12. And now I'm after the below diaphragm ribs. So I'm going to find your iliac crest, and while I'm palpating the iliac crest, I can feel her lower ribs, and her crest and her lower ribs are fairly close together. So I want to position the patient with the true PFR that we've listed for you, and that's the film's edge, 1 inch below the iliac crest. Take a second and palpate yourself. Find your crest and find your ribs. I'm fairly close together too. But women or men, there can be a lot of space between the rib that they're feeling and the iliac crest. There's a lot of space in there. You don't have to drop that film's edge 1 inch below the crest. The ribs are fairly high. Elevate the film a little bit. Your goal is to demonstrate the 4 lower ribs, 12, 11, 10, and 9. And if you have your film too low, you might clip that 9th rib. So you might have to alter the PFR a little bit. Palpate here, assess your patient's habitus, and adjust the part film reference point as necessary. But Kristen, her case, the crest and the rib cage is very close together, so I'm going to put the lower edge of the film 1 inch below the iliac crest. Okay. Crest, film's edge 1 inch below. I have to adjust my tube. Okay. And then side to side, again, you can use the baby light scenario right here. We're just getting a little bit of light there. And I'm analyzing to make sure I'm getting an adequate amount of the left side ribs. And I'm happy with that positioning. And now, if we're after below diaphragm ribs, you want to elevate the diaphragm. And to do so, you have them take in a breath and blow it out. And this time you want expiration. Blow all your breath out. Please hold it out. Don't breathe or don't move. And you can make your exposure. If the patient's in a nice AP position, the spinous processes will be to the center of the film, and the ribs are in a very transverse position. And that would complete a rib series. We need to set up a couple of different scenarios now. I'm going to come over here to the skeleton for a second, and you can see what we're trying to demonstrate. I just demonstrated AP ribs. AP, the patient happens to be lying down in this scenario, and we had right posterior injury scenario. We took 3 images, a big film above the diaphragm with the patient in an AP position. We took a small film for below diaphragm on a 10 by 12, and then we obliqued the patient. And that's what we're going to talk about here for a minute. I'm going to oblique the patient into an RPO position. And you can look right up this thorax here and take a look how we've taken these lateral ribs and we want them laid out. And then look what happened to the spine. It went over there. The spine is actually now under the left side ribs. These are laid out. These are going to be twice the size, twice the width as this side over here in comparing the distance between the spine and the lateral aspect of the ribs. If it was a left posterior injury, we would focus on the left side of the patient, above diaphragm, below diaphragm, but the oblique that we would do would be an LPO, like that, because we want to lay out the left ribs and we want the spine underneath the right side. Okay. Now, what happens if a patient fell forward getting into their bathtub and they hit the anterior injury, or hit the anterior side of the ribs? Well, you're going to choose to have them in a PA position. Okay? And let's set up the scenario that it's left ribs. So we'd focus on the left side. Again, we'd take a big film above diaphragm. We'd take a little film below diaphragm with the patient in a PA position. Some techs will actually turn the patient over to do the small film in an AP position because of the shortness of the lower ribs. They don't come around to the front, and the reason you do it PA is to get the injury side closest to the film, but the 11th and 12th ribs actually don't come around the front, so they do their 10 by 12 in an AP position. And I'll try to clarify that again in a minute because that tends to be confusing. But what we want to focus on with the skeleton here is the obliquity. We've taught you in previous lessons that when a patient reverses, things reverse. Okay? We were shooting APs. We were shooting with the patient's back next to the film. And when the patient's back was next to the film, when you oblique the patient, you were after the downside. Okay? A right side injury, you did RPOs. A left side injury, you did LPOs. You were after the downside. Patient is now reversed. Okay? So if you were after the downside before, what side are you after now? You're actually going to be after the away side. The criteria reversed. Away side. Let's demonstrate why. Okay? What position is the patient in now? The patient is in an RAO position. Right side closest to the film, anterior side closest to the film. What ribs have we laid out, and what ribs are going to be underneath the spine? See how we've taken these lateral ribs now and laid them out, and the spine is now over this side. This side will be twice as wide as this side. Okay? So if you're doing a rib exam for anterior injuries, you oblique the patient affected side away. Let's go to the vertical board and demonstrate this. We're going to set the scenario up for left anterior injury site. Left anterior injury site. ID to the top, L marker. Can you step away from the board for me, Kristen? 14 by 17 collimation. Okay. Elevate the board so the patient's chin's up on the rest, so you are 2 inches above the apices of the shoulder. Okay. Have them standing straight. Mid-sagittal plane to the center of the film. Feet spread for stability. And then just look and make sure you're getting the affected side on there, and we are. So I'm going to live with that mid-sagittal plane to the center of the film. Left marker on this side, I put on the cassette. Okay, and then she can just relax. Just make sure the arms are away from the board a little bit. There you go. And can you take in a breath, blow it out, take in another breath if you can, or just attempt one breath in, but do something to try to get inspiration. Okay? You take that picture and let your patient relax, change films. Now this is a left injury, okay? We're going to oblique the injured side away from the film in this case, so we're going to do an RAO. And since I'm after the left side, I'm going to leave the left marker on there because I'm after left ribs. Patient's height does not change, so I don't have to worry about that. But I'm trying to lay out these ribs here. If she was a shallow oblique, see how shallow oblique, my fingers are this way. I've got to oblique her more to where you are going to be more perpendicular to her lateral ribs. This arm would have to come up and out of the way of the ribs. And I'm after the left side, so I'm going to look right down here and only have a baby amount of light on there. I wouldn't do that because I'm giving the doctor no information at all. I'd bring her over here. And then I would have her take in as big a breath as she could, and I would make the exposure. She can relax. For the below diaphragm ribs, I would have to change my technical exposure factors because I'm over the abdomen. And again, many techs will just take the 10 by 12 and put the patient's back to the board, and I'm after the left side because her ribs don't come around to the front. So the lower ribs, which is our focus, 9, 10, 11, and 12, they don't come around, so they just get closer to the film. And we would change our collimation to the 10 by 12. Her hips should be at the same height, so I'm just going to use her iliac crest here, film's edge 1 inch. film's edge 1 inch below. And then step over here and look at the amount of light on the table. And then how would you breathe the patient? The shielding is below her ribs. I wanted to make sure that. How would you breathe the patient for below diaphragm ribs? You want the diaphragm to elevate. You want to have the patient blow their breath out. Do not breathe or do not move. Now, some other scenarios that you might get into is bilateral ribs. In Kristen's case, I might turn, well, she fit both ways, so I would just do one AP. I would have both ribs. I would do both obliques, and I would do both below diaphragms. If it was bilateral, somebody who's larger, you could take a 14 by 17 and go crosswise with that, crosswise with your films. The below diaphragm, Kristen's habitus, she's longer and not so wide. I'd leave the film lengthwise. But once in a while, if you have a broad patient, a tech will choose to turn the cassette crosswise for below diaphragm ribs. Kristen, you think you have anything to add, or were we pretty clear to the class? Okay, thank you. Bye-bye.